Welcome to this high-density execution protocol explainer. We've designed this specifically for the advanced practitioner, so we're jumping straight into the deep end. Today, we're training your clinical decision-making and aggressively stripping away the diagnostic noise. You know as well as I do, when you step into the trauma bay or the surgical ICU, you literally do not have time for second-guessing. You need first principle concepts, and you need absolute clarity. So that's exactly what we're going to build today. Here's our roadmap for the session. First up, shock kinetics and hemodynamics. Second, burn physics and resuscitation. Third, acute abdomen and trauma. And finally, we'll wrap things up with a mandatory validation drill. Let's get right to work. Module 1, shock kinetics and hemodynamic profile forks. Okay, to really master the first principle concept of perfusion pressure versus systemic resistance, you absolutely have to filter out the noise. Think about what we call step 2 noise, distractors like a remote history of congestive heart failure, or maybe just a mild, non-specific tachycardia. You've got to dismiss those immediately. Instead, lock your focus entirely on the absolute physiologic relationship between the heart's cardiac output and the systemic vascular resistance. That interplay right there, that dictates your patient's survival. Now think of this comparison as the judge's bench. We are forcing a head-to-head evaluation of the 3 primary hemodynamic profiles. Let's look closely at septic shock first. It's a distributive shock, right? Inflammatory mediators cause massive vasodilation. This drastically drops your SVR, which is pathognomonic, by the way, and the heart compensates early on with a hyperdynamic increased cardiac output. Now contrast that with cardiogenic shock. In that case, the pump fails, cardiac output drops, and blood backs up, which pushes your pulmonary capillary wedge pressure way up. In response, your SVR spikes as a massive, desperate compensatory squeeze by the peripheral vasculature just to maintain mean arterial pressure. So let's isolate the key variables here. Say you've got 2 identical hypotensive presentations. Both patients have cold extremities, low cardiac output, and a sky-high systemic vascular resistance. How do you actually tell them apart? The singular differentiating variable is the pulmonary capillary wedge pressure. A dropping wedge pressure means the tank is just empty. You're looking at hypovolemic shock. But a spiking wedge pressure, that means the pump is broken, fluid is backing up into the lungs, and you are dealing with cardiogenic shock. And remember, if you mistakenly push IV fluids on that broken pump, you are literally going to drown your patient. Moving right along to Module 2, Burn Physics, covering resuscitation and airway dynamics. In this scenario, we're anchoring our clinical logic on the epic battle between microvascular leak and severe thermal edema. Sequence is literally everything here. Step 1 is always your airway check. You're looking for singed nasal hairs, carbonaceous sputum, or maybe a hoarse voice. If any of those are present, step 2 is immediate endotracheal intubation. Do not calculate fluids yet, and definitely don't assess the total burn surface area. Why? Because thermal injury to the upper airway is going to rapidly trigger massive edema and completely obstruct the airway. If you wait, you lose it. It's only after that airway is totally secured that we move on to the rule of 9s and fluid titration. And that brings us to the exact execution math for fluid titration, the Parkland formula. It's incredibly elegant. You calculate the volume as 4 milliliters times the patient's weight in kilograms, multiplied by the percent of the total body surface area that's burned. But the execution of this math is the real kicker. You have to give 50% of that totally calculated volume in the very first 8 hours post-injury, and then the remaining 50% slowly over the next 16 hours. But hey, watch out for this huge high-noise distractor. You must never, ever factor superficial, first-degree burns, like your standard weekend sunburn, into your rule of 9s for the Parkland formula. You only count partial thickness, second-degree, and full-thickness third-degree areas. Also, your fluid of choice here needs to be lactated ringers. If you push massive amounts of normal saline, you run the risk of triggering a severe hyperchloremic metabolic acidosis. You're strictly titrating these isotonic fluids to maintain a solid urine output of at least 1 cc per kilo per hour. Let's transition to Module 3, the acute abdomen, where we'll tackle trauma versus obstruction. Okay, we really have to draw a hard line here between trauma interventions and mechanical obstructions. Think of this as a severity invasiveness scale that maps your patient's presentation directly to your surgical urgency. Notice the fork in the road? A hemodynamically stable trauma patient actually gives you the luxury of time to get a CT scan of the abdomen and pelvis. But an unstable trauma patient with a positive FAST exam, that buys them an immediate trip to the operating room for an exploratory laparotomy. That exact same urgency applies to peritonitis. If you feel rebound tenderness, guarding, or rigidity on your exam, you bypass the scanner entirely and head straight for emergent surgery. In a fast-paced clinical scenario, a bedside fast exam, focused assessment with sonography for trauma, is absolutely your best rapid diagnostic tool. If you've got a hypotensive, tachycardic patient with penetrating trauma to the chest or abdomen, you grab that ultrasound probe immediately to look for hemoperitoneum or a pericardial effusion before you ever let them near a CT scanner. In these moments, time is tissue, and more importantly, time is blood volume. Now, let's contrast that acute bleeding trauma with a mechanical obstruction. When you're looking at x-rays, the classic pathognomonic findings of a small bowel obstruction are unmistakable. A supine film will show these massively dilated, air-filled small bowel loops with basically zero gas down in the colon. Then, a lateral decubitus film will reveal multiple, very distinct air fluid levels that form a characteristic stepladder pattern. For obstructions, recognizing the shift from a partial obstruction to a complete ischemic one is a real game changer. A partial small bowel obstruction where the patient is, thankfully, still passing flatus can often be managed pretty conservatively. We're talking NPO status, IB fluids, and NGT decompression. But the second you see obstipation, new onset rebound tenderness, or a rising lactic acid level, you are in the red zone. Lactic acidosis strongly suggests necrotic bowel, which means conservative management is officially out the window, and you are rushing that patient to an emergency exploratory laparotomy. All right, it's time for Module 4, the mandatory validation drill. Let's test your immediate recall and application. So you've got the protocols down, you understand the clinical forks in the road. Now let's see how you hold up under clinical pressure. Listen to this presentation carefully. Vignette 1. You have a 22-year-old male brought in after a gunshot wound to the abdomen. He's wildly tachycardic at 140 beats per minute and profoundly hypotensive at 70/40. Your bedside fast exam reveals a large stripe of free fluid in Morrison's pouch. Think back to the severity invasiveness scale we just walked through. What is your definitive, absolute next move? If you said immediate exploratory laparotomy, you nailed it. You absolutely must bypass the CT scanner here. A gunshot wound below the nipple line, paired with profound hemodynamic instability and positive sonography, is a massive intra-abdominal hemorrhage until proven otherwise. This patient goes straight to the OR so you can stop the bleeding. Let's shift gears to Vignette 2. A 45-year-old female is rescued from a closed-space house fire. She's got partial thickness burns covering her entire chest, back, and right arm. But most importantly, she's speaking to you in a really raspy voice and coughing up carbonaceous sputum. What is the very first execution step you take right now? The answer is immediate endotracheal intubation. Before you even let your brain calculate her total body surface area, and long before you start crunching numbers for the Parkland formula, you have to secure that airway. The soot and the raspy voice guarantee an inhalation injury. That airway is going to swell completely shut, and if you delay even a little bit, you'll be forced into a messy surgical cricothyroidotomy on a rapidly deteriorating patient. As we wrap up this protocol explainer, I want to leave you with this final thought. Memorizing the complex physics of shock kinetics and trauma pathology, that's one thing. But when the monitors are blaring, the room is chaotic, and a patient's life literally hangs in the balance, can you filter out the noise and execute the single correct next step? I challenge you to carry this framework into your very next shift. Trust your protocols, ignore the distractors, and never, ever stop refining your execution.